Well, I'm back. Uh, we want to talk now about sort of the state of the science and thinking about early detection and care and potential ways to cope with Alzheimer's. Um, I wanted to start, since this looks like it's going to get pretty technical pretty fast, by asking Bill, can you fill us in on some of the basic scientific mechanisms of Alzheimer's, what we know about it, and specifically your work on your theories?
Okay. So my class takes 10 weeks, twice a week. We can do this in 2 minutes. No problem.
Yeah, no problem.
There's a statistic that I like. When I was in graduate school, there were 3 papers published on Alzheimer's every month. Now, there's over 1,000. So that's cause for being optimistic. Just keep that in mind. So what we're all looking for is something that's in the brain that shouldn't be there. And in particular, those things that might be toxic. So our work and a lot of the work that we're going to hear about today deals with these toxins in the brain. They're small. They shouldn't be there. They show up typically with age. And the idea is, how do they work? And what can we do about it? How can we get rid of them? Or how can we block their toxicity? So these are related to a normal part of brain metabolism, something that's referred to as a peptide called A-beta. You'll hear a lot about A-beta. You hear A-beta is a peptide that makes amyloid plaques. A-beta also makes small soluble toxins. That's the focus of our lab. So we introduced an alternative theory to Alzheimer's disease 20 years ago. And a lot of people probably think that it's the soluble toxins that are really the bad guys, the culprits.
So I kept up with all that.
I didn't do my job.
I'm right on track. Samantha, I wanted to move to you. It seems when we talk about drug development, one of the markers of Alzheimer's disease drug development is the failure rate. What have we learned, though, from those failures? What makes this such a difficult disease to predict and make useful interventions for, and where are we heading right now?
Yeah, Vann, so the failure rate is something that stands out for many people, and we first probably want to ask ourselves, so why does it look so high? Why has it been so challenging? And what Bill has just described is the evolution of the understanding of disease, which has been taking place in the last 20 or so years. But the unmet medical need, the desperate need to bring forward new treatments, has compelled us to try to bring forward new treatments while we weren't yet fully baked in our understanding of disease. So we're doing 2 things at the same time. Drug development is incredibly complicated, very long, and a very involved process. Understanding disease, if you understand it, you can identify the targets, and it makes drug development easier. So we've been doing both of them in parallel, making it doubly hard to succeed, if you like. But what we have learned is quite astounding. In that period of time, while we have refined our understanding of the mechanisms of disease that Bill has pointed out, most importantly, we've understood that the disease, so the pathology in the brain, starts more than 20 years before those first detectable symptoms. So you have this extremely long silent phase when the disease is actually starting to deposit the plaques in the brain, to cause tangles in the neurons. And so what that means for drug development is to best intervene in disease would be to start an intervention earlier in disease, so maybe before those symptoms are really robustly manifest. And so that's another complication that we've understood. Our original clinical trials were in people with overt symptoms quite far into the disease. Much of the brain has already been damaged and not possible to rescue. So we needed to move clinical trials into earlier patients. We needed better disease understanding, and we needed to be able to detect those patients.
So Samantha and Johan, your companies are involved right now in a collaborative effort. Can you tell us more about that and more about where we're headed on that front?
Yeah, so I work for Biogen, and we have a portfolio of programs in Alzheimer's disease. And while those particular programs are something we work on ourselves, how we go about our clinical trials and how we learn from the science is a massive collaborative effort. Understanding of disease does not occur inside the walls of any one institute. We collaborate with other industry partners. I have my colleague here from Eisai. We collaborate with many groups in academia to understand disease, but also those major NIH-funded initiatives that help us to improve our ability to conduct clinical trials, ADNI amongst them.
So, Johan, what should we be excited about right now? What should we cheer about when we leave this conversation? I want something to bring the pom-poms out about.
Yeah, I think it's a big question, of course, but I think there are three things that we're really very excited about today. And I think Bill touched upon one thing. We understand the basic science much better. We know what we like to influence. We know what we like to work with mechanistically. Also, the toolbox we can actually look into the living brains today. We have imaging techniques. You know, when Alois Alzheimer, Oscar Fischer, and Salomon Fuller described the disease 111 years now ago, they had histopathology. Now we have imaging techniques. We can look into people while they get the disease very early, and we can follow it. And I also think the most important thing is that we have very encouraging clinical trial data now. We actually see effects of drugs that we haven't seen before. We can do something on that pathology that we can measure, the amyloid and tangles or whatever it may be, and we can also see clinical effects. We see trends for having good clinical effects, and I think that's the most encouraging bit. So those three pieces are coming together, and now we're at the time when we can really start to try to deliver upon those three things together.
So, Elli, you have worked on a digital product. I think this is something that's blowing my mind right now. Can you tell us more about it and about how we might be thinking more about treatment, about tracking, about early detection in ways that don't necessarily involve pharmaceuticals?
Sure, absolutely. So at Neurotrack, we take a very different approach to the disease. We look at it as something that is potentially delayable or preventable through lifestyle, and have built a product on that theory. We have run our own studies, and the data is extraordinary. It's building on the work of scientists out of Europe and also here in the United States. What our view is that there are lots of different ways that we need to be attacking this disease. There's clearly the pharmacological way, but there's also this preventive solution. And our view is that while we're waiting for a drug, and we hope it will come very soon, that there are lots and lots of things that people can do. As Samantha said, the disease starts 25 years before symptoms show. So we're missing this massive window of time when we should be identifying the disease and giving people the tools around exercise and diet, real things that they can do to prevent the disease. We put that product out in the market. We've had incredible response from people in more than 165 countries. We have millions of frames of eye tracking data. We diagnose through eye tracking, and we're onboarding those people in the preventive solution. So our view is there are lots of different approaches to this disease. We want to give people that opportunity before it's too late. And we think we can work with pharma to help be part of the ecosystem and develop a drug eventually.
Samantha, you introduced a concept that I thought was very interesting earlier, talking about how we've changed our understanding of how the disease works in a really radical fashion. I want to ask the group, has the infrastructure, the support for clinicals, for drug development, for thinking of outside-the-box intervention and solutions, has that infrastructure caught up to the current understanding of how the disease works, and how can we encourage it to do so if not?
So if we think about clinical trials, and I mentioned that we are needing to conduct clinical trials to test our potential new therapies in patients much earlier in disease. What that takes is we are testing for very subtle symptoms of cognition, so the earliest stages of disease, but we are confirming that they truly have disease by the brain imaging that Johan mentioned too. Brain imaging is one way. Another way is to test proteins in the cerebrospinal fluid, so to do a spinal tap. Those two methodologies over the last 5 to 10 years have become robust enough for us to use in global clinical trials. So I'm using them in over 300 hospitals in the world, but they are not part of standard of care. And today, diagnosis for a patient entering the healthcare system, the regular healthcare system, not the high-tech clinical trials, does not use these methods as standard. We see them seeping into these centers of excellence. We see them starting to be used in some European countries, but they are not part of the pathway today. They are not reimbursed by the healthcare system. And so that's a hurdle that we will have to overcome. Should we be successful with one of our treatments in the next couple of years, that will be a fundamental piece of the system that will need to change.
Just to add to that, there has been an increase in funding, and it seems like a lot, but it amounts to about buying 1 cup of coffee for everybody in the United States. That's how much the government spends on Alzheimer's research.
Wow, 1 cup. Is it Starbucks? Or?
Well, you know, a tall, not
okay.
a grande.
Okay, not a grande.
Yeah.
I wanted to follow up with you, Bill. You mentioned, your research came out of a place originally where it's, considered a countervailing theory. When we're talking about funding, there's also a conversation about what gets funded, sort of whether we're talking about innovation or frontier research. How do we encourage that level of innovation?
So you kind of are born with an interest in doing something different. That's how innovation begins. And then you have to pursue it and defend it. And I remember when we introduced the concept that we had a number of years ago, I went out into the hall after I talked about it, and people were saying, can't be true. We would have discovered it. So, I mean, it's a competitive field.
Johan, we got to the point talking about, we're talking about private partnerships, but what space is there now, and what's the state of the public-private partnership? We're talking about public funding. Bill said it's not enough, but with the funding that we have, what's emerging on the level of public-private partnership?
Actually, there's a long tradition in the Alzheimer's field to work together in private-public partnerships, and there's a famous effort called ADNI that we worked on for now, I believe, 13 years or something. So we have come together very early in this space, and we actually learned to operate in a way where we can share things in a much constructive way between pharma industries, between academicians, and ADNI is a prime example of this because the data is immediately posted. Anyone can be a scientist with ADNI data. It's immediately accessible to anyone. But there are many efforts like that. And we're building now infrastructures also for clinical trials where different organizations come together and build big networks. Because the big problem we have in this field is actually to get people to the trials, which is strange because there are millions of people out there with the disease. But we need to get the right people to our trials, and that is a big effort. So we reach out and we work together in different networks. We have different screening tools that Elli was mentioning, and we try to work together, different companies, diagnostic companies, pharma companies, and Eisai has for many years been involved in this with leadership in different roles, and other companies have done this for many, many years. And I think this is going to help our not only the late development pipeline with all the tools that we need to have, but also the coming products that we all work on that will influence different parts of the pathology. So I think all those technologies I spoke about before, they really progress together in a joint community work.
Getting people to the trials, if we're talking about getting younger people who may have a different understanding of the disease, there may be some stigma attached to it. How is there a role for public education for getting better understanding of Alzheimer's and lowering that stigma in making sure we have the right trial populations?
This is a very important question. I think Harry talked about this before. The view on the disease has changed. Even the name has changed. When I started, it was senile dementia. If you remember that.
Oh, yeah.
Yeah. And now it's Alzheimer's disease. And I think also the cases with so-called dominant mutations have also changed the view. There are people that are doomed to get the disease. And when you meet those families, they have a very different attitude to the disease. They live with it. But in terms of early detection, we start to get the tools now, but they're not out there in the community. We could do more in terms of promoting people to test themselves. There is an issue even with your regular GP visit. They don't really test for cognition. You ask a lot of things, but never really about your brain, which I think is a big mistake. We can do much more in the awareness also in the medical community, not just in the general community.
You know, the education issue is a big one, because we heard from Harry also that there's pathology that changes before any behavior changes, 20 years before. So if people are aware that there's silent toxins appearing, they might be interested in chasing those.
And I would say that, I don't think we have anywhere near the level of education and public. This is where public and private partnerships really start to matter. This notion that this is an old people's disease is just not true anymore. And I think, beginning to really educate people around the role of brain health and taking care of your brain and starting that process very, very early is really important. People should be testing, beginning in their 40s and thinking about their brain as an organ that they take care of just like anything else.
Well, Elli, when we talk about tech, the role of tech in detection, I think about myself as a 29-year-old person. I will do anything if it's on a smartphone. Is that something now where we're seeing people who are more savvy and more interested in using tech? You see people who are now so interested in genealogy to determine whether they're going to have a disease in the future, people who are really interested on that level because tech is sexy and interesting.
Yeah.
Are you finding that that's
absolutely
making it easier?
Yeah, absolutely. I mean, so at the end of the year, we'll launch our new product, this prevention product, and a whole new suite of cognitive tests, all on the phone. And when we've done this in the past through, very light advertising, through the traditional, social media and other places where younger people go, we've had tens of thousands, hundreds of thousands of people sign up, take our test, and that's unprecedented. I think there's a role for pharma, there's a role for digital. We all need to be working together, because if we don't, we're really not going to make the kind of progress that we need to.
I want everybody come up with some good questions. Want to have those queued up in about a minute. Bill, wanted to say my last question for you. I love doing this as a scientist. It's my favorite thing. What is out there on the horizon? What do you see maybe breaking, developing in our understanding?
I see a treatment, so it's going to happen. These guys are very close. That treatment may be in their bag of tricks.
See a treatment?
So
wow.
I'm very excited about that. And then I think we're also going to go down deeper and get into this preventative issue. What is it that's causing these toxins to appear in the first place? And can if you do what your mother told you and eat right and sleep right and exercise, will you prevent those toxins from showing up? So I think that's good advice, by the way.
Well, do you want to open the floor for questions? We have one here.
Sure. Mike Kornkowski, I'm a pharmacist with the College of Pharmacy. Very interesting discussion. It seems like there's two bifurcations here that are very important to me. One is the metabolic basis of this disease, and do we have a truly a model that we could study drugs? Can we grow brain tissue in a petri dish and study drugs in a meaningful way? And then do we have a valid, non-invasive surrogate marker that could truly diagnose this disease? Because the testing you're explaining is very invasive, and it's something that the average public is not going to understand. So I'm looking at, is there a horizon of a surrogate marker that's valid? When can we pee in a cup and you could tell me what's going on? Make it simple. And then, truly, I mean that. And then ultimately, is there a model for growing brain tissue to better study the disease very homogeneously? Thank you.
Maybe I can have a first go at it. Yeah, thanks for that question. I think it's a very important one. And we talked about the different technologies that are developing now. This is a very complex disease. We have amyloid plaques, tangles, neurodegeneration, inflammation. We start to have all those markers, and they're to some degree invasive today, but there are a lot of good efforts with blood diagnostics, new analytical platforms, new analytes that people are looking at. So I think the whole spectrum of the disease, all those pathologies I just mentioned, we start to be able now to measure in blood. We start to see some idea how to monitor what goes on far from the blood, up in the brain, out in the blood system. And we actually apply that in our trials already now. We test out those technologies. And we try that also in our earlier research. We try to develop new technologies in our research labs, academic labs, industry labs, and diagnostic labs. So I think we will eventually get to a stage when we can much, much earlier detect the disease. And Bill talked about the many, many years when the disease is silent. It's there, but it's not clinically detectable. And I think we'll come to a stage pretty soon when we'll be able to actually to tell people you are actually on a trajectory to the disease.
No?
So I like working with brain cells in a dish. I don't like working with animals, but in a disease like this, you have to work with animals. For example, what's the relationship between the emergence of toxins and diabetes? You can't see that in a dish. Or the relationship between traumatic brain injury and the disease. Turns out TBI has the same toxins as Alzheimer's disease. And so microparticles in contaminated air, they have a potential for causing these toxins to appear. So it's
TBI,
traumatic brain injury, or the football player's injury too.
And Bill, the animal models, though, have been developing along with us to enable us to test new potential drug candidates. So we talked about this as a disease of metabolism, and perhaps another word to use is homeostasis. These proteins are normally made in the brain. And so at their normal levels, they have a job, a function. And what we're talking about, the homeostasis goes wrong. Either too much is made or not enough is removed. What we can do is model that in small animal species. And that has been very helpful to us to test potential new molecules to interfere with either the production or the reduction and look at both sides of that equation.
Thank you. My name is Angel Alvarez. I run the stem cell core at Northwestern University. The question I have is, given that the physiology, is 2 decades before the symptoms truly emerge, how do we know that the mechanisms that we're targeting for these drugs are really the ones that we should be targeting early on? Is there a different pipeline that we should be developing, different mechanisms that we should be targeting for someone who's young, before they develop the symptoms, versus one when the symptoms are already rarely present?
I think so.
Yeah, well, we can try again. The question is extremely good, but that's all the efforts we are actually embarking on right now, actually trying to figure out the sequence of events. And there are some famous curves that some famous scientists have drawn on how the different things come, the timing of events. And the timing of events are now mapped out with various biomarkers, imaging techniques. So we are now in a better position to time out what's going on. And we are more and more interested now to go earlier and earlier in the disease. More and more studies are actually preclinical, pre-symptomatic studies, where you pick up those early pathologies and trying to do something about them in the idea that there is a cascade of events going on. And amyloid is one of those still key favorites that we like to address because it comes very early. And if you take that out of the picture, maybe you can delay or maybe even stop the later events from occurring.
Yeah. Let's see, one question, one more.
Oh, okay. Hi, Rebecca Levin from McCormick Foundation here in Chicago. We've been talking a lot, or you've been talking a lot about all different modalities of addressing the disease, and I haven't heard anyone say anything about Eastern medicine or non-Western approaches, and I wondered whether or not that's a robust piece of the work that you're doing in collaborating across domains.
So while we haven't mentioned Eastern medicine, what we have heard referred to is being healthy in your midlife. So what's good for your heart is good for your brain, good diet, good exercise, and in Alzheimer's disease, over and above that, very good social connections as one ages. We also haven't referred to that education is a protective factor for Alzheimer's disease. So we are, continuing to understand, holistically what there is in one's life that is helpful to delay or prevent the onset of Alzheimer's disease. And I think those areas do have a lot of our attention. With respect to Eastern, we are global companies. We have branches, personally for our company, in Japan and China, and Eisai is based out of Japan. So we have contact with academic institutions across the world. So should there be something promising, it doesn't really matter where it comes from. It doesn't matter what type of medicine it comes from. If it were to deliver on the aim of slowing or stopping disease, we're interested.
And with the aging population in China, they're becoming very interested. So one of the best postdocs from my lab who discovered these toxins in the brain is in Nanjing, and he works in traditional Chinese medicine as a possible way of dealing with it.
If I may add, being a Japanese company, of course, we're more interested in this, and we study a lot, of course, drugs on the platform of different lifestyles and ethnicities. And this is a big question for us in the trials. The clinical outcome measures we have to be translated and culturally adjusted, but also the background medication people have. We are actually at Eisai now pioneering big studies in China. And we're in the midst of building that kind of infrastructure for a modern trial, but also have to build that on that particular background of the population. So I think this is a very important question because we are, of course, facing a global disease and we like to do something against it across the world.
Samantha, my wife, watches all of the live streams of these, and I'm pretty sure your words about being healthy are going to come back. I'm going to hear them again. I want to thank you all for coming, and thank you all for your great questions.
Thank you.
Thank you.